Welcome, everyone. It's the top of the hour. We'll get started. I'm Dio Agasback in Houston. I'd like to welcome you to today's GlomCon. Today is part of our Clinical Trials Conference Series, which is a joint venture between GlomCon and NephCure, and our title is Targeting the Podocyte as a Treatment Approach for FSGS. Before we introduce our speaker and panelists, I want to remind you of NephCure's mission, which is to accelerate research for effective treatments in rare forms of nephrotic syndrome and to provide education and support to improve the lives of those affected by protein spilling kidney diseases. And one of their resources that they have is this Kidney Health Gateway, where their physicians, patients, family members of patients can go in. And it's a really nice resource to find out about clinical trials that your patients, a family member, or you yourself may be eligible for and in your area. So with that, we'll get on to our introductions. So today's speaker is Dr. Sandi See Tai. Dr. See Tai is the medical team lead for amyloid, rare cardiac, neuro, and renal and global product development at Pfizer. She leads cross-functional medicine teams for proof of concept to first major approval and co-leads through end of life cycle development activities. She is also responsible for strategic clinical planning for early stage development candidates and technical due diligence for business development opportunities. Sandi has 17 years of experience with the pharmaceutical industry and medical affairs and clinical development at Wyeth Pharmaceuticals and Pfizer. She has worked across multiple therapeutic areas, although her main focus has been kidney disease and transplant. Prior to joining the pharmaceutical industry, Sandi was an assistant professor of pediatrics at Drexel University College of Medicine, an attending physician in pediatric nephrology at St. Christopher's Hospital for Children in Philadelphia, where she completed her general pediatrics residency and pediatrics nephrology fellowship. She received her MD from Tufts University School of Medicine. After her talk, we'll have a discussion with her and our panelists, Dr. Kirk Campbell, who is a professor of medicine and director of the nephrology fellowship program at the Icahn School of Medicine at Mount Sinai. In addition to treating patients with kidney disease, he leads an NIH-funded research program focused on developing new therapeutic interventions. He actively participates in clinical trial testing novel agents for primary glomerular diseases. He's past president of the New York Society of Nephrology, a member of the board of directors of the NephCure Foundation, and a member of the medical advisory board of the National Kidney Foundation serving Greater New York. Our other panelist is Dr. Suneel Udani. He is a clinical nephrologist with Anani, a single specialty nephrology private practice in metropolitan Chicago. He's also the medical director for the practice's research division. His clinical and research work is focused on glomerular disease and cardiorenal interaction. He currently is the PI in multiple industry-sponsored phase 2 and phase 3 glomerular disease studies. And with that, I will turn it over to Dr. See Tai and we will get started.
First of all, I'd like to thank GlomCon and NephCure for the opportunity to share this program that we've been working on at Pfizer. And some of the topics that I'll cover today is just a brief background on FSGS, and also share why and how we selected the program that we have to move forward in development for FSGS, and take the opportunity to share some preliminary data that we have from our ongoing phase 2 trial. So with that, I'll start with just some basic background in FSGS. And as you all are well familiar with, it's a rare and progressive kidney disease that can affect renal filtration and may lead to end-stage kidney disease. In the US, the prevalence is estimated to be about 40,000, though these numbers are estimates. I don't think they're very good counts, at least, that have been reported in the literature. What we do know is that at least amongst adults with nephrotic syndrome, that FSGS accounts for about 40% of those cases. With FSGS, there's a disproportionate impact on Black patients, where we see Blacks 4 times as likely to have FSGS as whites with nephrotic range proteinuria, and in turn have a 4-fold greater risk of end-stage kidney disease due to FSGS when we look at Blacks relative to whites or Asians. The disease presentation can vary, though I think proteinuria is pretty much a central finding for all these patients, though to different degrees. And we know that for some patients, they present with very acute onset of proteinuria versus others being a very gradual or insidious onset. But at the time of presentation, nephrotic range proteinuria is quite common, affecting about 2/3 to 3/4 of patients. And patients often have some degree of microscopic hematuria, affecting about a third to half of patients. And hypertension is quite common in 40 to 65% of patients, and that some patients, up to half of patients, may actually present with renal insufficiency at that initial presentation. And so from a clinical standpoint, we do try to classify the disease, primarily thinking about it in terms of being primary FSGS or idiopathic, or having a secondary cause. And it's somewhat important to distinguish that in terms of thinking about the potential treatment options. And so probably universally for the patients who have proteinuria, one would consider treating with ACEs and ARBs. And in primary FSGS, really consider the appropriate use, whether it's appropriate for patients to use immunosuppressive therapies that includes corticosteroids or other immunosuppressants. And while these treatments are effective, there are some high rates of treatment failure or relapses. And a particular unmet need today is the fact that a significant proportion of patients, despite available therapies today, do progress to end-stage kidney disease. And in particular, those who have nephrotic range proteinuria, more than half, so about 50 to 60%, progress to end-stage kidney disease within about 5 to 10 years. And for those who do go on to have a transplant, unfortunately, there's a recurrence rate of about 30 to 40% post-transplant. So as you all know, there have been histologic classification system, probably well known as the Columbia classification system, that looks at classifying based on findings primarily under light microscopy, where one has these various categorizations that are listed here on the left side of the slide. But despite those histologic variants, by light microscopy, what's really a common finding is ultrastructural findings. So those on EM, where we see podocyte alterations. And the typical finding would be diffuse podocyte foot process effacement that may or may not be accompanied with detachment and loss of podocytes. And so with podocytes being the common theme in centrally affected cells across the variants, that really serves as the basis for why in our program we've chosen to really focus on the podocytes and a potential therapeutic target in that area. The pathway that we focused on is the Robo-Slit pathway. So, how did we get there? Why did we select that as a potential therapeutic approach? So the how and why of why we chose this really rests within the discovery of this patient who had bilateral grades 4 to 5 vesicoureteral reflux. And in this patient, one might expect that over years, without correction of that VUR, that the patient may exhibit some degree of proteinuria. And for this particular patient, over the years, on repeat urine assessments for urine albumin, the measurement has been 0. So not just a small amount or trace, but really 0 protein in the urine. And what was discovered for this patient is that the patient actually carries a chromosomal translocation that disrupts the ROBO2 gene. The patient has one normal copy of ROBO2 and the other is fused with the Y chromosome. But the chromosome breakpoint occurs directly after the ROBO2 ligand binding protein. And we'll talk a bit more about the role of ROBO and Slit. But if you look at the right side of the slide, what seems to be the case here is that with the ROBO2 translocation, you have loss of function. And so during the development phase of the kidneys, you can have the finding of vesicoureteral reflux. But following development, maybe that ROBO loss of function seems to be protective in terms of proteinuria. So let's talk a bit more about Robo2 and Slit, and at least in terms of how we understand it today. And I'm sure there's still a lot more to be learned and understood about the pathway. So Robo is a family of proteins. Robo stands for roundabout guidance receptor, and it's a family of proteins numbered 1 through 4. They're single pass transmembrane receptors for Slit 1 through 3. And RoboSlit was first described as a repulsive signaling pathway to regulate neuronal migration and axon pathfinding. But beyond the CNS, Robo and Slit actually plays a critical role during kidney development and ureteric bud outgrowth, such that if patients have mutations in Robo2 or Slit2, they are associated with urinary tract birth defects such as vesicoureteral reflux, like described in the patient that we reviewed on the earlier slide, and congenital anomalies of the kidney and urinary tract. But after kidney formation, Robo2 expression is gradually restricted to the glomerulus, and in particular, localized to the foot processes and the basal surface of the podocytes. However, its ligand, Slit2, is expressed throughout the kidney, including the glomerular basement membrane. Its function in adults is less understood than during development, but seems to play a role in inhibiting cell adhesion and actin polymerization. So what do we understand from knockout models? What we see is that the podocyte-specific loss of Robo2 appears to be renoprotective. So in a nephrin knockout model, Robo2 actually alleviates or almost normalizes the glomerular characteristics in a nephrin knockout. And that if we look at Robo2 podocyte cell knockouts, we see that it protects the mice from podocyte loss, it reduces foot process effacement, and protects the mice from induced podocyte injury. So given that loss of function and inhibition appears to be renoprotective, our potential therapeutic approach here is using a Robo2 fusion protein with understanding that by neutralizing or inhibiting this pathway, we may improve or protect podocyte structure as well as adhesion. And so we can use this to actually impact the glomerular filtration barrier to hopefully reduce proteinuria and in turn slow renal function decline. So the key here is in using a Robo2 FC, which serves as a Slit ligand trap, that we would inhibit that pathway, and by doing so, increase the actin polymerization in the podocyte and improve its adhesion. So we then took this approach into the passive Hayman nephritis model, and granted, it's not a model for FSGS, though at least a means to test this hypothesis in an animal model. And by using this approach in administering the Robo2 FC, either at day 0, so before the animals develop proteinuria, we do see that subsequent to its administration that we do have lower amounts of albumin in the urine. But we also repeated the experiments starting dosing later after the onset of proteinuria. And in that case, the amount of urine albumin is also decreased when administered Robo2 FC versus the control. So as we would normally do during clinical development, is we first go to a phase 1 study, which are generally, not universally, but generally conducted in healthy volunteers. And in doing so, our phase 1 study included a single ascending dose and multiple ascending dose study. And what we learned from this study, two major points, is that our compound, which I'll refer to as PF512, was well tolerated with an acceptable safety profile. We saw no infusion reactions because it is administered in this study as IV or sub-Q. And that also what we saw in terms of exposure was that it was generally linear. So it increased in a dose proportional manner across the range that was tested. So from there, we progressed to a phase 2 study, which is in patients with FSGS. And as we thought about developing that study, as we go into patients with FSGS, we really had to think about what is an appropriate endpoint? What can give us an early signal for efficacy to give us confidence to keep moving forward with clinical development? And as we've done in this program, as done in many other renal programs in development, is use the reduction in proteinuria as a measure for, as an early marker of efficacy. And so, you know, what gives us the, I guess, the confidence to use proteinuria reduction as that surrogate is the fact that there have been studies and multiple publications that I'm sure you're all familiar with, which links the reduction in proteinuria both with the what we call the hard clinical endpoints, or the endpoints which are linked to renal survival, but also to eGFR slopes. And what we see is if we look at proteinuria reduction, not just in terms of complete or partial remissions, but any degree of proteinuria reduction as a continuous measure, which is on the right side of the slide, that you see an incremental reduction in the decline of eGFR. So based on this, this really supported us going into the phase 2 study in FSGS patients using urine protein to creatinine ratio, looking at the % reduction as a measure for efficacy, at least as an early marker. So what I'd like to share here is the design of our phase 2 study in FSGS, and it's called the Podo study, which looks at PF512 in patients with FSGS. And again, this was just based on our first look at the data. So it's based on our first interim analysis, and these data were shared at ASN Kidney Week earlier this year. So at a high level in terms of the study design, we are planning to study multiple dose levels in this study. And of course, the purpose of the study is to evaluate the efficacy, safety, and tolerability, as well as the pharmacokinetics of this molecule in adults with FSGS. And it's an open label study. So all patients receive active drug with dosing that is IV every 2 weeks. And these cohorts are dosed in sequence. So at the top right of the slide, I refer to the primary endpoint, which, as I shared, is the % change from baseline in UPCR at week 13. We also include an optional biopsy sub-study, and I'll talk a bit more about that in a minute. But it looks, what we hope to show from that sub-study is to actually measure the podocyte structural changes quantitatively using EM. And then what's across the middle of the slide is showing that we are dosing cohorts in sequence, where we start with a high dose cohort, we go to a lower dose cohort, and then we have added an optional third dose cohort such that it would be an adaptive design. So based on our learnings from the first 2 cohorts, we can decide on what would be that third dose cohort that we may need to evaluate. But within each cohort, it basically consists of an 8-week lead-in period, followed by a 12-week treatment duration, and then a 9-week follow-up period for safety. We are currently, based on the data that we've seen today, rolling out an amendment that would aim to extend the treatment period from 12 to 24 weeks. And again, we have planned interim analyses at approximately when we're halfway through each cohort and then at the end of each cohort. And so the preliminary data that I'm sharing today is the data from being halfway through the first cohort. So the main inclusion criteria are patients with FSGS, biopsy confirmed, and all adult patients at this stage. We have proteinuria, an inclusion criteria around proteinuria where patients who are included need to have greater than 1.5 grams per gram. And patients must have been treated with at least one class of immunosuppressants or at least be intolerant or have some contraindication to receiving an immunosuppressant. Patients also need to have an eGFR greater than 45, though we do permit inclusion with GFR of 30 to 44 if they have a recent biopsy, and that's more so to ensure that there isn't a high degree of tubulointerstitial fibrosis if they are included with the lower range GFR. And if patients do come in on an immunosuppressant or on ACEs or ARBs, that what's preferred is that they come in on a stable dose and remain on a stable dose throughout the study so as not to confound any efficacy findings in the study. So this first slide just goes over the demographics. So again, on the first interim analysis, we acknowledge it's a small number of patients. And this analysis, again, was to assess the potential to stop the study early for futility, which turned out was not needed. And we'll share the data on that. And the drug was generally well tolerated. We had one participant discontinue study treatment after the fourth dose. So we had 8 participants complete through the week 13 assessment. However, all 9 participants are included in this primary analysis. So if we look at baseline demography, I think, one of the things that I'd like to highlight here is, of course, in all adults, the mean age was 42.7 years. We have 44% females. The representation in the study is 100% white at this point. Of course, having a more representative population that's consistent with the general FSGS population is extremely important, and we hope to have a more diverse population as we continue to enroll in this study. We have a small percentage that are Hispanic or Latino. But I think what's really worth noting from these baseline demographics is around the baseline characteristics in terms of UPCR and eGFR. So very high nephrotic range proteinuria in terms of looking at the median UPCR. And patients in this study, at least in the first half of this cohort, have compromised renal function where the mean eGFR is about 50. And the vast majority of patients continued to receive their ACE or ARB ongoing throughout the treatment period. So this slide shows the primary efficacy measure, which of course was focused on the UPCR reduction, and it's looking at UPCR based on 24-hour urine collections. And what this result showed was that at the end of the treatment period, we had an approximately 35% reduction in UPCR. So we're looking at change from baseline. So it's a within patient comparison over time. In terms of safety, the safety data we believe supports continued development. We've had no significant safety signals to date. There have been no deaths, no severe or serious adverse events related to the drug, or as determined as related to the drug as per the investigator assessments. And so our study remains ongoing as planned with expansion, as I mentioned, of the dose duration to 24 weeks rather than the 12 weeks that we had in this first subset of patients. So here I'd like to share the finding from a single patient in the biopsy sub-study, which I had briefly mentioned as I talked about the study design. So it is an optional biopsy sub-study. So patients that participate can decide if they're willing to participate in this or not. And like I said, we have data from a single patient. So definitely limitations in that regard, but I think the data are interesting and intriguing, and I think at least worthwhile to discuss briefly. So for patients who participate in this sub-study, they have a first biopsy during the lead-in period or just prior to the lead-in period, and then undergo a post-treatment biopsy. And I'm sure you can understand why or how we ended up with only one patient so far, in that, in general practice, we don't routinely perform repeat biopsies in our patients. So I think while it proves to be challenging, I think the data can prove to be meaningful. So in this single patient, what we wanted to share is, as I shared, it would be assessing foot process width. And this is done by doing multiple evaluations within an image that's looked at under EM. And what we found in this patient is a significant reduction, almost 40% in the foot process width. And I think that these data are very interesting in terms of thinking about the potential mechanism by which we believe our molecule works. And so with that, we're happy to share that these data support the continuation of our phase 2 study. So the data again showed a statistically significant and clinically meaningful reduction in these initial 9 participants in the study, and that's following 12 weeks of treatment. We haven't seen any significant safety signals to date. And the study remains ongoing. So it's a global study. As you can see, we currently have 54 open sites across 11 countries, and we are still expanding and adding sites as well as countries. And if you want more information on the Podo study, I've included the links here, and certainly anyone is welcome to reach out directly to me as well. And so with that, I'd like to extend a heartfelt thank you to the patients with FSGS and their families who enable us to do much of the work that we do to support them and help find treatments to help them. And particularly to say thank you to you as well as researchers and clinicians, whether you're investigators or clinicians who refer patients to investigators, which is also critical to advancing development and developing new medicines for patients. And thank you to GlomCon and to NephCure and all the other advocacy organizations for your passion, expertise, and engagement in helping to advance clinical research and care for FSGS patients.
Thank you, Sandi. We have some questions coming up in the chat, and then we'll bring in Kirk and Suneel as well. First, I just wanted to ask more of a brief question about the Robo2 and its location. Is it located in other cells in the body where inhibition may provide some adverse effects or negative effects or side effects you may be looking out for from the safety profile?
Yeah, so I think there's still quite a bit to be understood in that regard. I think following development, so particularly following the early postnatal period, it really, the Robo2 Slit pathway really seems to have much less of a role, whether it's in the, particularly in the CNS, which is where one would be particularly concerned about. And so research has suggested, or at least what's been published, is that that significantly drops off in the months postnatal. But I think more to be understood. Yeah.
Okay, thank you. And then I think one of the big questions that I think we can have a lot of discussion on, one is the heterogeneity of FSGS and our understanding of the disease process, right? And so, we can, like I said, bring Kirk and Suneel in to comment on this as well. But there's also been some questions in the chat of, we're targeting a lesion versus maybe the mechanism of disease, and how and why that approach may work, or should we be trying to understand more for FSGS, a specific disease, versus maybe this is applicable to other diseases because we're targeting something more downstream. So if you can comment on that, and then I'd like Kirk and Suneel as well to comment a bit on that.
Yeah, I think there I think multiple potential therapeutic approaches, and I don't know that there's one right way or wrong way. I think it's hard to know at this point, and I think the way that we think about many of these therapeutic approaches is probably needing to use multiple approaches. I don't know that we understand enough to think that a single approach would address the needs of all patients. And so I think what's great is that there's development that looks at many different potential approaches, and I think there's potential for them to be used together in the future.
And Kirk, if you can comment on kind of what's going on in FSGS, maybe research, and what genetic things we should be looking for to best kind of put these patients into maybe different groups, so that as these trials are coming out and we're not targeting one specific pathway, how we can best think about putting patients into different, different therapeutic options, and what may work best for them.
Yeah, thanks so much, Dia. Yeah, as I think a lot of folks in the chat are alluding to, and as you mentioned, really this is a histologic lesion we're talking about, right? Not necessarily a disease, right? So we have a number of different underlying etiologies, and it is true that there are intersecting pathways that may be relevant for a number of different underlying pathogenic etiologies. But at the same time, for FSGS, I think we're getting a better understanding, as you're alluding to, of the genetic contribution, right? Where there are many series that are suggesting that 20–30% of patients with FSGS may have a monogenetic etiology, and that's not even including disease modifiers like APOL1. We're understanding a lot more that the primary disorder, as Dr. See Tai mentioned, may be more amenable to immunologic therapy, right? More of an immunologic basis, right? To patients who present with the nephrotic syndrome and have recurrent disease post-transplant. I think that we're seeing data from the UK Radar and Mohan Salim's group, that when you rule out a genetic etiology, the recurrence of FSGS isn't really in the 30–40% range as we previously thought. It may be more like 70%. So there really, is a heterogeneity that we're going to be appreciating more as we can do more genetic testing. But at the same time, as Dr. See Tai mentioned, there will unlikely be a silver bullet, and we may require combination therapy. So it's really important to have these studies adequately enroll patients, so that we can see what the efficacy and safety signals are, so that we can make a more informed decision, right, as to what treatment options may be, that we may be able to use together, right? I was intrigued by the passive Hayman nephritis, in vivo model, for example. That's a membranous model, right? So when we start thinking about podocyte injury as a downstream readout in proteinuric kidney disease, what other disorders could an agent like this potentially work in? And I think, that'll be an interesting question going forward.
Thank you. And Suneel, can you comment on, in your practice, how you kind of approach these patients? Are you doing genetic testing on certain patients and that type of thing to better understand their disease process, maybe in a common kind of day-to-day practice for maybe someone who's not at a large academic center and you're enrolling in clinical trials as well? But how do we bring that to the community to then get patients into trials, better understand their disease, and a new approach to treating them?
Yeah, no, to echo Kirk's comments, I think that these things have to go in parallel, because if we wait for more underlying etiologies to be defined, it could be another 2 decades before we have anything there, and our patients simply can't wait. We know that in day-to-day practice, the complications of FSGS, so finding some downstream pathways that may be shared amongst different etiologies of FSGS becomes important from a clinical trial and therapeutic intervention standpoint. From the standpoint of how do we identify them, that's really the difficulty, though, because again, we're talking about a very rare disease, and if you start to subdivide them further and exclude patients based on further subdivisions, the ability to enroll patients becomes very, very difficult in a disease that has been already difficult to execute clinical trials. So it does behoove them, both the clinician as well as the investigator, to try to, in their best clinical judgment, using the tools available, make a rational subclassification that is appropriate for that potential trial. So I think steroid responsiveness still still seems to be the first branch point, despite our ongoing, discomfort with the complications of steroids. We know that steroid responsiveness sort of puts you in a different category, and that does sort of suggest this immunologic pathway. And so then when we think about which trial would be appropriate for which patient, if they do need that, that they have steroid responsive, we think that the immune system is really the thing to target. Am I really going to refer them for a trial that targets something very different? It still may work, but do I really have the equipoise that's necessary to believe that that is the best thing for the patient? On the other hand, steroid resistance brings in that whole other category of FSGS, including genetic, adaptive, potentially toxic, et cetera. And so genetic testing, because its availability now, which is really quite accessible, at least in the US, has become part of our routine practice, especially in individuals that are steroid resistant. I think it's sort of a necessity, if you have access to it, to do genetic testing in someone who's steroid resistant, because you don't want to then commit them to pathway of recurrent courses of immunosuppression, which we know are not going to work. And to the study designers' credit, they have now more and more included. When we talked initially about study design, it was really about primary and secondary, and initial studies included genetic causes as secondary. Now they've parsed it out more and saying we'll include primary, whatever that means, including genetic, and really trying to best you can exclude the purely adaptive FSGS, but that's still obviously not always so clear cut.
Thanks. And Sandi, are you including genetic testing as part of the initial characteristics of patients, and then being able to collect data to stratify results for subgroup analysis in the future?
Yes, so we don't have it as part of the inclusion. We are collecting samples from patients that will enable us to test after the fact and look at the data in that context. So we could have the opportunity to look at it in that regard.
And I know in some studies that I participated in, the genetic testing is always an optional part. So is it optional, or is it included as part of the study trial design?
I believe it is included. I would have to check to answer that definitively.
Because I think that's another point of too. Sometimes it's can be a challenge if it's an option, understanding why it's an optional, but a separate consent oftentimes for the genetic testing. All right, and then I think another question that's come up a couple of times in the chat would be about one, the method of administration, and is that going to limit participation? And then the second part of that, I think, is the drug action, and you're targeting a pathway that you're inhibiting something that's ongoing. So much like we talk about, and we've talked about in this kind of forum of calcineurin inhibitors in lupus, and when you stop them, does a proteinuria return, that type of thing. Can you comment on kind of expectations of that? Is this going to be a lifelong type therapy, or what are you guys thinking?
Okay, so the first around the method of administration, we recognize that an IV infusion is not is not ideal. Obviously, you know, most convenient for patients would be if it were an orally administered drug. Recognizing that we are planning to explore the ability to do whether it's IV infusions at home as opposed to having to come into centers to get the medicine administered, and alternatively also exploring the ability for subcutaneous infusions that could be done at home. So I think, yes, it's challenging, though I think, you know, one has to wait for each patient, you know, the benefit risk to each patient. And so, you know, what may be appropriate and tolerable for one may not be for another. So I think it would have to be individualized, but recognizing that it can be inconvenient, that we are exploring ways to try and make it more convenient for participants and patients. In terms of the other question, which was, hang on, please remind me of the question. It was on, oh, in terms of durability of effect, whether you actually have to administer the drug on an ongoing basis. I think we still have to learn and understand that. One is our mechanism does not seem to have a hemodynamic effect. And I would say that the preliminary data, at least that I showed, is that even 9 weeks after the drug is administered, so during our safety follow-up, we still see durable reduction in the proteinuria. So I think there's still much that we have to learn and understand in terms of durability beyond, you know, what the effect is after stopping the drug. But for the time being, I think we are saying that it would likely require long-term administration.
Thank you. And then Dr. Suki had asked if you were storing the urine samples to identify any microparticles to correlate with the podocyte injury.
Yes, we are. And we are evaluating, you know, markers, whether it's, you know, podocin, podocolexin, and other markers.
And thank you. And then Dr. Cabrera asked about why exclude primary idiopathic collapsing FSGS to those most in need of therapy to slow progression.
Yeah. So, you know, it's always a fine balance when we think about the inclusion and exclusion criteria. And I think, you know, often when we start in the earlier stages of development, we tend to work towards a more homogeneous population, and a population that you think may be most likely to demonstrate some response or some effect. And I think as we go to later stage clinical trials, tend to have or work to be more inclusive and a less, perhaps a less homogeneous population. But it's trying to find the right balance of how do you, I think, efficiently demonstrate a potential treatment effect early on versus going forward into more a real world population.
All right, thank you. And then I'm going to read off Dr. Glassick's comment and question, and then I think we'll open it up because there's a lot of questions coming in, and see if everyone would like to ask directly, and let Kirk and Suneel also ask some questions and comment. So Dr. Glassick had wrote the entry criteria for the Podo trial with the 1.5 grams UPCR without consideration of serum albumin will likely mean that the underlying mechanism for the lesion will be very heterogeneous. With the movement to precision medicine, will the value of the trial be limited in patients with specific diseases like FSGS due to Alport's, or primary due to a permeability factor?
I think very interesting question, and I think it's early on where I think we still have so much to learn and understand about our drug and its pathway. You know, and so at this stage, I think trying to collect as much data as we can, and at the end, when we have the results, look at whether, you know, what the variables are or factors that may impact or play a role in terms of individuals' response to treatment.
And then maybe Kirk, you can, and Suneel can kind of comment on that as even a broader of a lot of the ongoing FSGS trials, and how, data we may have reported in the next year or two, if we have a better understanding, are going to be applicable.
Yeah, absolutely. And then I also would like to ask a question, right, in that regard to Dr. See Tai. But yes, I mean, I think that's always the balance. I think we're still in the early stage of development for agents in this space. Obviously, we don't have anything specifically indicated, but ultimately we want to move towards a more precision-based approach, right, where you can use urinary, serologic, histologic markers to identify patients, right, who might be most responsive to specific therapeutic agents, right? That's where we ultimately want to go. And I think that, obviously there are some precision therapeutic trials ongoing. And in that regard, I guess, one question I had for Dr. See Tai was if you could comment on some of the deliberations around the open label design, right? I think it's not the most common, right, in this space, but we do see some studies doing this. So what are the pros, cons, the pro and cons, and why ultimately did your group decide to go with the open label design?
Yeah, great question. And I think we deliberated that one for quite some time. After discussing with several clinicians, I think, the recognition, one, it being a rare disease, and really trying to optimize, or maybe not optimize, but maximize our learnings from as few patients that are needed to actually demonstrate what we needed to know. We ultimately decided that if we look at, the trade-offs in terms of if we do have a placebo control, we would need perhaps more patients than we have. And so that trade-off in terms of patients' willingness to enroll in a study to get an IV infusion that may be placebo, is certainly a consideration that we weigh. And ultimately, where we landed as the alternative to that is the single arm study. But what was critical in deciding that would be acceptable is setting up a fairly long lead-in period, which gives us enough time to establish what's the patient's baseline. So how much variability is there in that lead-in period? Because if we're using the patient as their own control and looking at change from baseline, it really became critical to establish what that baseline was, and not have a patient changing by a couple grams of protein during that short period of time, and then not having the ability to really understand the impact of the treatment intervention itself. So I think those were factors as we as we designed the study up front.
Thanks.
Yeah, to the Dr. Glassick's point, as always, right on the head. I think that we're definitely going to get a heterogeneous population, and as Kirk, I think, can attest to, most of the studies are designed a similar way with this proteinuria cutoff, and without necessarily a serum albumin cutoff, without a specific pathologic criteria cutoff. And so especially when we're going to do these small studies, it's going to be difficult to see what is really happening, but we hopefully will see some degree of an idea of what the impact is that will lead to a larger phase 3 where there's actually a randomized trial, and where we can get numbers perhaps, and it's still optimistic, that we can start to separate out those individuals within the trial and how they responded. I think we're seeing some of that in some of the other ongoing trials, that the degree of proteinuria reduction can be is good, but depending on what your baseline is, it may not be enough. And so just being a successful trial, that will not necessarily mean it's going to be the wonder drug for everyone. But I think at this phase, and we're still, how many failures have we had with FSGS over the last 2 decades? And so the fact that there's investment in this space, the fact that there's development in this space, I think it behooves us as a community to support it as rationally as we can.
Thanks, Suneel. And I think for the last 10 minutes or so, we can open it up to any other questions that the audience may have, any other points you guys would like to make. And you guys can unmute yourself if you'd like. Please just say your name and where you're joining from.
I mean, the one comment I would like to make is just, we've talked about this before in the clinical trial series, but this idea of where clinical trial referral or enrollment for a patient, where it fits in their sort of management algorithm or management pathway. And I think that, again, as nephrologists, we haven't had this many options, but as you can look at in on the NephCure Gateway or clinicaltrials.gov, there are now a multitude of FSGS trials and other trials in rare disease. And so, trying to, again, fit into where, at what point that we refer patients to those trials without being beyond the point of no return, for one. And secondly, without including our own biases. We have, anybody that's treated FSGS, we all kind of think we have our own little cocktail that works, but we've done that, again, for the last many years, and it's led us to a standard of care, which is essentially just RAS blockade. And so when you talk about comparator arms too, the comparator can only be the standard of care. And so it leaves us, it leaves people sort of wanting more from the trial. But again, it's our own actions that have to change that.
Yes, and I think something, interesting point brought up with the optional biopsy post too. It was kind of the, some of the inclusion criteria for different FSGS trials don't, the biopsy is anything historical. So you don't know where you are in the disease process, whether they have activity, scarring based on even the pathogenesis, right? And so definitely can, especially phase 2, can skew outcomes because we don't know what that patient was, started with at that initial trial criteria. And I think that's something where I know we've discussed here as a lot of as well of the maybe the importance of the biopsy, as hard as it can be sometimes, but to at least help us with better understanding trial results, because we may be missing out on a potential targeted therapy just because the inclusion didn't include a recent kidney biopsy, right? And we had a lot of fibrosis that we didn't know about.
One question for Dr. See Tai is, and this is not unique to this trial, but the general exclusion of post-transplant FSGS. And in some ways that, it can represent a more homogeneous population. So why not is a question to look at that as a separate, either a separate study or a sub classification within this study.
Yeah, I think certainly a consideration for the future. I think when we start out, again, it's, thinking about all of the other medications, concomitant medications that the transplant patients are receiving, and just trying to sort of understand particularly the safety and tolerability profile of a new drug in development that, you try and maintain. Again, it's about maintaining some degree of relative homogeneity within the study population early on, but that's certainly a consideration for the future. Yeah.
This is Dr. Lieberman. I had 2 quick questions, if I could ask. One is, where have you thought yet about when you want to extend down to younger age? Maybe I'm a peds nephrologist, and I was curious when this might be available to our adolescent patients. But the second question I had is a broader question for the community, and actually for NephCure in a way, which is picking up on Suneel's point, which is our biases are certainly going to influence our decisions. It certainly has influenced my decision as to what trials to recommend to what patients. And we do have this enormous embarrassment of riches. And I'm wondering if we as a community, perhaps with NephCure's help, need to start to think about how we are going to help prioritize studies, how we are going to be more homogeneous in the patients that we recommend for different trials, and in a more organized way, perhaps even prioritize trials to make sure that promising agents will receive the N that they need.
Okay, so I'll take the first part of that question then, around consideration for, the inclusion of pediatric population, particularly adolescents. And, we've definitely started to think about that and when is the right timing. And from our standpoint, we felt that that the data that we have at the moment, I would say, is preliminary. It's in a small subset of patients, where it's 9 patients to date. We felt that if we have greater confidence in the findings, so meaning in a larger number of patients, so at the time that we get to the end of the first cohort, if the data continue to be as promising as these preliminary data set looks to be, at that point we would be considering then expanding into the adolescent population, and then working, which we typically do, then gradually go to younger populations once we establish some degree of efficacy and safety in the adult and then the adolescent population before considering younger patients.
And this is Josh from NEFCure. It's good to see you, Dr. Lieberman. With respect to promotion, or I shouldn't say promotion, but advocacy of one trial over another, in our position, we have to remain the honest broker. And what's interesting, though, if you look at the trial selection process from the patient's perspective, often the decision is made, which site is near me? Is my clinician involved in that study? And if you look at the natural inclusion-exclusion criteria of each of the trials, that seems to be a big factor over which one is chosen by the patient. And it's often linked, frankly, to who their glomerular disease specialist is and who's involved with the trial. But as far as one trial over another, I spent 34 years on the pharma side before coming to not-for-profit, and you never know which drug's going to make it. And I've lost more bets than I can count on which ones would. So I'd be hesitant to say, hey, let's back this one or another one.
But I guess going forward, I think we can agree that if we have agents that are proven to be efficacious, figuring out a way to use them as a part of a multi-target strategy will be important in the future. So I think this is sort of the first step, but I agree with Josh. It would be difficult to prioritize one over another at this stage. Right?
Hi, Dia. This is Kristen from NEFCure also. I'd like to just point out that, I get a lot of referrals from the patient community around clinical trials. Since I joined NEFCure, I've done a lot of clinical trial education, trying to debunk a lot of the myths around participation in clinical trials, and what does it really mean to be in a clinical trial. And so I have to say, one of the biggest aspects of me encouraging or educating patients to be in clinical trials has been not only around the education piece, but also getting them to know or to be empowered to talk to their own physician about clinical trials. The reality is that that most of the patients don't see doctors that are PIs in clinical trials. I mean, it's rare for me to connect with a patient and say, oh yes, I am a patient of, let's say, Dr. Poon-Mayer. And so yes, he can connect me with a clinical trial. It's just not happening as much as we want. So first of all, I usually try to engage them in a conversation, obviously around their disease state. A lot of times patients will share their biopsy reports, their most recent lab work, that sort of thing. And so based on that, I will kind of make a list of trials that they may be eligible for. And then from there, if they, I try to discern, are they empowered enough to really discuss this with their own physician? Or do they need a second consult? Do they need a second opinion? And so where I can connect them with a NEFCure specialist, this curated list of glomerular disease specialists, and a lot of times these are PIs in clinical trials. And so in there, it's interesting because a lot of times in those consults, patients are exposed to treatment options that have never been discussed before. And a lot of times they have Have you considered a clinical trial? So I think that conversation, more broadly, more broad spectrum needs to go towards the general nephrology community around engaging patients. And I'm not sure that there's an easy answer to that, right? But there is a lot of work around our part as, being NephCure, that it is a more, making a list, what would they qualify for? And then based on some of that conversation, yeah, I can say, you might be more interested in this trial or this trial. I have to say that, the inclusion of pediatrics, I think, is also a big point, because I think even in the adult population, I think it broadens their view of, oh, this could be something, that could work for more people. And so anyways, that's my comment around, NephCure's, engagement in the patient community. And we look forward to doing more, as this progresses, because there's a lot of clinical trials out there, and we know that we need to get patients in them.
Thank you, Kristen. All right, well, we're at back to the top of the hour, so I think we will wrap up with that. I want to thank everyone for joining. Thank you, Dr. See Tai, for excellent presentation and sharing your guys' work to try to find more disease treatment options for our patients. And thanks to Dr. Campbell and Dr. Udani for joining us in the discussion, and everyone who participated to make it very fruitful. And we'll see where the future will bring us, and we'll be back together again to discuss more soon.
Thank you, everyone.